I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is the transition from volume to value. Dr. Dan, how are you doing this evening?
I'm doing great, Faisel. This is an exciting topic and an exciting guest.
I am so thrilled about tonight's topic. Dr. Dan will be co-host and will be moderating the chat, bringing in your questions and comments with our very special friend this evening. Our friend is Dr. Vivian Lee. Welcome,
Hey,
Dr. Lee.
great to be with you guys.
Thank you so much for joining us. You know, your book, for the audience members who haven't read her book yet, her book really offers an optimistic action plan for reform. And it's for anyone. It's for employers, it's for payers, patients, clinicians, policymakers, anyone who wants to know how we can reform how healthcare is delivered in this country. This is the book you have to read. We'll be putting a link in the chat where you can go to Amazon to order yourself a copy, and we'll remind you again at the ending of the interview. So Dr. Lee, let's get started. My first question for you tonight is around medical debt. Medical debt is the number one cause of bankruptcy in the country today. And now 1 in 5 Americans they're in some stage of debt collection because of this, including myself. Actually, my wife, just in the last week, received a debt collection notice for a test she recently had. As a country, we're approaching $4 trillion in healthcare spending. Please respond to those in the audience or those listening who believe that we must reduce expenses by cutting care.
Well, it's so funny to hear that story because that actually happened to us too. And in fact, when I was the CEO of the health system at the University of Utah, we actually got into some trouble for one of my family members who, just had a little medical visit. So I know exactly what you mean by that. And for us, we're very fortunate because we're connected into the healthcare system. We can get these things sort of straightened out. But for most people, it's serious. It's actually really, this issue is not a lighthearted matter. It's not one that they can really laugh about in the way that we, hopefully your wife and you also can laugh about this soon. It's a very serious matter. And your question is really, I think, the core reason why I wrote The Long Fix, right? Because I think so many people here, we are spending so much money on healthcare in this country. It's about 17, almost 18% of the US economy. It's almost 1/5 of the US economy. So how can we sustain that? We've got to just cut care, right? The only way that we can kind of manage the financial piece of it is to cut care. But actually, you and I and Dr. Dan, we know that's really completely the wrong answer. And the fact that we are spending 2.5, 3 times as much on healthcare per person as any other high income or developed country is not because it's because we're actually spending that money in completely the wrong way. And in fact, 10% of Americans still don't have health insurance. They're still not covered. And COVID is just making that all of them more terrible. Really, all of them are terrible. So we just have to change our healthcare system to a way that actually I think ChenMed has really exemplified, where instead of just paying for more and more care, spending a lot of money that's wasted, a lot of money on administrative costs that are completely unnecessary. Instead, we need to really get bang for our buck. We need to really get value out of our dollars in healthcare. And if we do that, we should be able to spend less and have much better outcomes and much better health and much better public health, frankly, in this era of COVID, top of mind for all of us. So that's really what we need to focus on.
I agree. I mean, we agree. We're kindred spirits. Yeah, 10% of the country is uninsured, and of course, you mentioned how many people are functionally uninsured. They can't afford their copays or deductible.
Exactly. Especially now with the rising, high deductible health plans, that where we're sort of shifting that responsibility and burden on to employees. It's, you've got to pay out of pocket the first several $1,000s. It's really crushing people. And it's actually not really making them healthier, because it turns out that they're really just foregoing all care because they don't have the money to afford it, including the preventative care that's actually free for them since the Affordable Care Act. They should be able to get the free screenings and the free vaccines and so on. But they're even foregoing those with the high deductible health plan. So that's definitely not the solution either.
I mean, and then your book, you mentioned about life expectancy actually continuing to decline, despite the fact that we're spending all this money for this healthcare system. So the rest of the world is getting healthier and living longer. But meanwhile, American babies born in 2017 have a life expectancy of 78 years versus Japanese babies with a life expectancy of more than 84 years. So that puts us at number 26 out of 35 in the OECD nations. So why is that? And what are some things we can do to close the life expectancy gap?
That is such a serious statistic, and it was one that really surprised me, when I started looking back into this again for this book and for other purposes, to think that there might be 4 or 5 or 6 years difference in life expectancy for the babies today. That's just really unimaginable. The story really becomes even more clear when you look even more deeply into the data, which is that it's not that everyone lives that much less than the average baby born in Japan or in Israel or in, say, Switzerland. It's that it's so uneven in this country. And we know that there are areas where just one zip code or one county next to the other, there can be differences of even 10 to 15 years in life expectancy across those communities. And so I think one of the biggest issues for us is the really huge inequities really in health across the American population. If you're fortunate enough to have health insurance and to have access to health care, then actually your life expectancy is going to be pretty comparable to these other nations. But far too many people don't have that access. And that's really the biggest challenge for us, is we need to be able to make sure that everyone, I think you started this in your opening remarks for this show, everybody needs to get access to health care. And we know especially primary care and prevention. I mean, that's where we need to invest our dollars, not waiting too late for somebody to come into our emergency room with a heart attack and the stroke. That's too late. Those are all preventable, almost all preventable conditions even today. So that's what we need to invest in. I actually just heard this morning when you were doing your opening comments, it reminded me of something I heard this morning where someone said, you know what it's like right now where you can, at least in a lot of parts of the country, you can go to one of the pharmacies and you can get your free vaccine shot, and you don't have to think about how am I going to pay for that. That's how all of healthcare should feel.
Exactly. We have centers in NOLA in New Orleans, where literally the center is located in the zip code where the life expectancy is in the mid to late 50s. There's a 25-year life expectancy gap in NOLA between one zip code and the other, and we have centers in the one where the need is. And we see that in Chicago. It's like 15 or 16 year life expectancy gap based on where you live in Chicago, and more than 10 years now in New York, which is unbelievable, between Manhattan and Spanish Harlem. So access to care.
It's access to care. And that's where, the young people today can really make a difference, right? When I speak with medical students and residents and fellows about how they should be thinking about the future of healthcare, I say, you really need to find a place where you can make a difference. Don't get cynical about all the things that you can get cynical about. Instead, if you can work in these environments that are so positive, where there is such a need, you can make a transformative difference in the lives of so many people. It's just really, there are very few things you can do in life that can make that much difference. And working in those communities that you're talking about in practices like ChenMed, that's exactly the kind of impact that these folks, I think that they want to make. And so I'm really, I think I couldn't say enough about how important that is for the future.
Those are the neighborhoods we're in. All our centers, every time we go to a city, our usual response when we go to the city and we meet the local people is, really? In that part of Detroit, that's where you want to open your centers? Don't you realize that's where all the gunshots are? And we're like, we view that the areas of greatest need are, for us, the areas of greatest opportunity. Sorry, Dr. Dan.
No, that's okay. We've got our first question. This is from Assad, and he's asking, is it not the need of the hour to identify, and I think he means all the stakeholders of the current healthcare system, and convince them to meet on a transition model to value-based care? And I think especially for you having run a large health system, there were a lot of competing interests, and my guess is primary care wasn't necessarily the rainmaker for your system, but it's obviously going to be very important for the value-based care model. How do we bring the stakeholders to the table to discuss the needs?
Well, it's a great question, because one of the things that it really reflects is the fact that it's hard to change things in healthcare because there are so many different stakeholders. And everybody right now, I think one of the things that makes our system so dysfunctional is that everybody now seems to have disparate interests. And really the patients are kind of left in the middle, right? I mean, or they're sort of not left in the middle. They're really left out of it. I call it, actually, I have this part in the book where I talk about the $1 trillion tug of war between insurers, the people who are paying for healthcare, and the providers and the patients. I just picture being sort of pulled by both ends and definitely not winning in this game, right? So one of the really important things about having a payment model like value-based payments is that it creates an alignment, a much better alignment between the payers and the providers, who in turn can both be channeled towards how are we actually really helping patients. And one of the reasons why I wrote this book is to have an audience of people who are patients. Okay, we're all patients in some form or another. At least most of us were born in a hospital. And of course, providers, healthcare providers, very important. But also the payers and the policymakers. So at the end of every chapter, I have, here's the action plan. Here are some of the recommended actions for you in any of these roles. And so this idea of, as Assad said, bringing everyone together so that they can be on the same page and understand how their interests can be advanced in a value-based model is exactly spot on. That's exactly what we need to do. And COVID is, maybe the little silver lining, if I can say that there is any silver lining in COVID, the little silver lining is that it is creating an imperative for everyone to move forward and accelerate, because there's been so much stress on the system. So even though my book is called The Long Fix, I'm actually thinking that was written before COVID. With COVID, I'm thinking it's not such a long fix. It's going to be a much quicker fix. We have to get there faster.
When you mentioned about having access to the vaccines, how people can just go anywhere and get the vaccine, not worried about how much it costs. Yeah. We have been seeing that since we started vaccinating. We started getting access to vaccines and vaccinating our patients in the community at the primary care offices. Many patients in the neighborhoods where we serve, it takes, even in Tampa, to get from where many of the patients live to some place like Raymond James Stadium, where we had our Super Bowl. We have many patients who it can take them upwards of 2 hours to take buses to go get their vaccine at one of these large vaccine sites. And those same patients will come, and they'll come to the center because we'll provide them an Uber. And when you ask, like, our average patient is 72, 74 years old. It's not just vaccine hesitancy that the underserved are delaying getting their vaccines. It's like what you said. It's about convenience and access. So we're blessed that we can provide Uber Uber transportation. The first patient that we vaccinated in Tampa was Ubered into the center, and he thanked God that we were able to Uber him in there. He delayed getting his vaccine because it was convenient for him. He was scared of being on the bus for a couple hours and waiting in a line, and that whole process went since he's been hunkered down for the last year.
Well, that's one of the many things I learned when I came out and visited the clinic in Miami at ChenMed was the shuttle service. And to think about all the expense and all the misery and suffering when a person who just needs to see the doctor and get their prescription filled again, or something's not quite right, and so they might be teetering on a pneumonia, but man, if we could just do a little intervention, it'll be all right. And that's just it's just that one Uber ride or one shuttle ride difference. I mean, it makes so much sense to provide that. Just so many things that, again, if you have the payment system aligned, I feel like you liberate the physicians and other clinicians to think proactively about what's in the best interest of the patient, right? Instead of just, I've got to code things, I've got to type more stuff into my EHR or whatever. In this case, it's like, okay, well, what do you think makes sense? And physician groups and other clinicians step up and are just very commonsensical about how to spend those dollars. And really, as you know better than anybody, really helping patients stay well. So it's a win-win. It's not only about keeping the patients better and financially doing well. It's also about really empowering and engaging our physician forces who are, reaching kind of epidemic burnout levels. So how can we create that virtuous cycle and have those physicians really engaged and empowered to do the right thing? I think it's really, really important. Really great what you guys are doing.
The relationship isn't there. When the relationship's there, when we treat our patients like family, then every patient gets a daily text message. Every patient gets a weekly phone call. I know if I don't call my mom at least once a week, I'm going to get a text message. Why didn't you call? And that's the world we live in. A monthly visit is routine. I mean, we even call the love calls. We call them love calls. The weekly phone calls that the staff make to the patients, we call them love calls. Well, this brings me to my next question. There's a huge misunderstanding in the country with regards to medical error, and with medical error being the third leading cause of death in America. It's really quite frightening. People don't realize how healthcare in the United States is actually much more dangerous than they even know. So what are some steps that we in healthcare can take to help reduce the danger with medical errors, and also to help inform the public? Like, hospitals and emergency rooms aren't necessarily the safest places to go when you're not feeling well.
This chapter in the book was one of the hardest for me to write about because I'm very sensitive to the fact that I would say there's always a few bad apples, but with the exception of those rare few bad apples, everybody that I know in healthcare is really trying to do a good job. People are really committed. They're working their tails off. It's not an easy life. It's not. And that's not why we came into. We came into to do good. So writing about medical mistakes was really hard for me because it feels like you might want to blame individuals because mistakes. I mean, that sounds like an individual doing something wrong. But really what I discovered, the more I read about it and the more I thought about my own experiences of seeing issues in the hospital, it's our system is really broken in healthcare. And we know it. All of us know it because it's just disjointed. There's not a coordination. Communication is not particularly strong. And there's just not the right incentives, again, to make those investments to do it the right way. But I think that a few things that I've learned from thinking and writing and reading about others, the great work that other people have done, is one of the biggest drivers in medical mistakes is beyond communication is just the high variation in care. The fact that we don't follow common practices, we don't follow standards and guidelines as much in healthcare as we probably can. Now, it's true that caring for people isn't exactly like working in an assembly line in a factory. Every patient is different, but there is enough evidence in the literature now to guide, I would say maybe 70, 80% of our care can be, following these guidelines. And if we can do that better, in healthcare, I think we would reduce a lot of mistakes. If you follow a typical nurse on the ward, everything that they have to keep track of, and Dr. A wants this antibiotic, Dr. B wants that prophylactic, and Dr. C wants, everybody's got their own protocol. And then people are interrupting them all the time. And it's no wonder that that nurses, doctors, everybody in the system is prone to error, because the system is really not set up to be friendly. Most electronic health records are not set up to be particularly user-friendly in terms of transmitting the most important information, right? That's not why they were built. They were built to be these giant billing machines for the most part. So I think there's a system level problem, and I write about in the book, and I have some recommendations for systems. I also, for health systems, I also write about, again, for individuals, which I think is also just as important. I think it's really important that patients understand and that they're as engaged as possible in their healthcare. And we do our best to share with them what they really need to know in a way that they can absorb it. Sometimes we give them all these instructions just when we know that they can't really pay attention or absorb what it is that we're telling them,
Yes.
So we need to convey that better. We need to get, right? And they need to be able to understand what they can do to help avoid mistakes. And similarly, I actually have some recommendations for physicians beyond these issues. I say, work in a place that's high quality. Whenever I talk with when I was at the dean of the medical school, and the medical students were ranking the residency programs that they wanted to decide where to go in the match, I would tell all of them, look at the quality of the systems. They're all ranked, right? Look at them. And because working in a high quality system, first of all, you want to imprint on those lessons, just like the little ducklings, you want to imprint on a really high quality system. But also a high quality system is investing in whether it's the physician-centered approaches, whether it's the lean management, whatever it is that's going to drive better quality. You're not swimming against the tide when you're working in a high-quality system. And I think that's actually really, really important for most physicians and trainees to recognize that they should be bringing their services for the good of a better system, rather than trying to change a low-quality system, which I think is really hard.
It is. I was actually earlier today at one of our centers in Lakeland, Florida, with one of our new doctors who joined us straight out of residency. And one of the points that came up, also with our average patient being 72, 74 years old, that means that they graduated high school sometime in the 60s. And in 1970, in the entire country, only, like so far as college education is concerned, only 12% of Caucasian men in America had a 4-year college degree in 1970. And the number for African American men drops by 50%. And then after that, you'll see Caucasian females, and then going down to African American females, like somewhere around 2%. Then you can imagine with our patient population, that's for the entire country. But when you're in the underserved neighborhoods, like at that particular center I was at, is surrounded by two homeless shelters. So they're dealing with a patient population, the particularly sensitive patient population. They may not understand how the method that you learned how to explain the significance of controlling blood sugar, when you're surrounded by entire teams of people that all have at least a 2-year or 4-year college degree. So if the patients don't understand the doctor, then it's on us, at least in the full risk world.
We have a lot of work, I think, that we can all do in this space in terms of improving communication, but also using additional tools. One of the things so now I work in the technology sector, right? I work for Verily, which is Google or Alphabet's healthcare company. And I see so many opportunities for using technologies to help reinforce messages that we may deliver in person, so we might be giving some good instructions. That's great. But wouldn't it be nice if they could also get it in their native language, in a YouTube video or in a document that they could read when they're at home with their family members who can go over with them? We could do things much better. And I think we're just on the cusp of that. You guys are probably doing better than most of the rest of the country, but I think we can, I see that that's just around the corner. It doesn't require a huge investment, and people are very motivated to learn and understand what they need to do, so.
Yeah, we could call it something. I got for my 13-year-old a next gen Xbox. It's like the new Xbox. So this sounds like next gen primary care, where we'll be like the way Netflix knows what shows we like to watch, when we like to watch them, which parts of the movies or whatever it is. Our primary care doctor of the future will know. Hey, you're spending more time at the bar than you are at the local park. Or how many steps you're walking per day, or your resting heart rate has been changed. What's going on in
Yeah, or you've been eating some, like, did you forget which foods have high sodium or, that you need to be avoiding for your hypertension, and which, like, here's a little refresher, Yeah.
Well, the audience doesn't know this, but Dr. Vivian Lee is in New Zealand. And thank you for joining us from New Zealand.
My pleasure.
I was so impressed to learn about how, and now it's picking up in America, but in European countries, many European countries are adopting like hospital at home care. I find that so fascinating, and it makes so much sense. All the errors that happen, or all the tragedies that happen with, especially the elderly being admitted in the hospital when they wake up confused, and there's so many different issues around that. But why do you think Medicare is so slow at adopting like hospital at home care?
Well, this has been a topic I've been so interested in for a long time, because it does make so much more sense, whether it's in Europe or in Japan, I think also, and also in New Zealand and Australia. They've been really doing hospital at home for much longer. People do much better at home, as you say. Falls is a really common issue in the hospital, and it's definitely better at home. And all the sundowning and all those other issues. And I think that change is slow. A lot of it has been because I think that hospitals haven't been that keen or haven't really been able to develop it. We don't have the workforce, frankly, for doing hospital at home. For example, the nursing workforce that's been trained up in the UK is very different from our. We either have visiting nurses who tend to do less acuity, lower acuity care, or hospital-based or medical facility-based nurses, for example. So we don't really have the staff, and we don't have haven't had the payment models for it. But I'm seeing that change. One of the areas that we're very focused on in the digital space is digital sensors and technologies to help monitor people in the home. So whether it's things like continuous glucose monitors for people with diabetes or blood pressure or pulse ox. A lot of people have been using these actually during COVID, and of course had really terrific results with it. So I think we're seeing Medicare, of course, Medicare is already moving towards more telehealth adoption, but let's just think of that as the beginning. Telehealth, more digital health, health at home, hospital at home based care. I think that's I think going to be pretty inevitable. But we need to do some work to make sure that we have the right workforce, that we actually have the right models of care to be able to do it at home safely. So I think the healthcare people and the business of healthcare with Medicare, we gotta work on this together.
Yeah, they're probably thinking like, hey, let's stop doing primary care in the emergency room and at the specialty. Let's do primary care and primary care before you talk with us about doing hospital at home care.
Yeah, a little bit one step at a time, but we have to move there. It's so much less expensive, for the system. It's the right way to go.
Totally agree. Well, it's that time. We need to take a quick break for a 20-second commercial. I had several questions for Dr. Lee. I maybe we'll be lucky to get maybe one or two more questions in before the end. So let's take a quick 20-second commercial break, and then we'll be back to talk about transparency and wrap up this tonight's episode.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. And just like that, the time has gone by so fast. Dr. Lee, I need to see how it happened. But before we end, I'm hoping I can squeeze in 2 quick questions. One is around transparency. We as doctors, clinicians, we improve quality of care by learning best practices from each other and sharing health outcomes, or the end results, as you call them. How can we develop this learning health system where how can you have that when there still remains such a lack of transparency?
Well, there is a major national movement to improve and increase transparency. So, part of the theory of the way in which we run healthcare as a business in this country, which is a little bit different from most of the rest of the world, is this idea that if we can be more transparent about costs and quality, that consumers will shop for better care and use their market power to drive better value in healthcare, right? That's part of the theory. And so, especially, I'd say the previous administration, the Trump administration, really was pushing transparency, but it's actually been pretty bipartisan focus. So we are going to see more transparency. I think the transparency, though, is going to be more effective in a business-to-business level than a consumer-to-business level. And what I mean by that is I think it's more important, for example, for the primary care physicians at places like ChenMed to look at use transparency to evaluate, let's say, the hospitals or the specialists that they may refer to. So if you have more data about, this group of doctors over here tends to do more procedures, more interventions, more operations, and not necessarily better outcomes than this other group of specialists, then you're going to want to know that so that you can make sure that you send your patients over to the higher value specialists or higher value hospitals. And that's what I mean by B2B. It's the doctors who can probably judge that better. Also employers who are part of the business, who need to decide where to send their employees for care, having more transparency will help them make those kinds of decisions. So I think transparency does have a big role to play, but to go with the transparency, we have to have standards. And what I mean by standards is we have to use the same language or the same unit of measurement. Like, are we talking about, I'll give you an example in my own space, I do MRI. Are we talking about an MRI of the brain with contrast, or an MRI of the brain without contrast, or an MRI of the brain with an angiogram and contrast? Yeah. So if we're going to compare costs, then we have to have standard terminology about each of the unit of service and not use different words in every different hospital, so we can't compare anything, which is the problem right now. And then folks like you, employers, insurers, can actually say, okay, now let's compare outcomes and those costs for those units of service. So we have to do that. Transparency plus standards.
We need that. We definitely, because you're right. And even in one city, you have 20 different hospitals talking with each other in 20 different measurements. There's no unified way to explain cost. Where does the cost come from, for example? Well, Dr. Lee, thank you so much for a wonderful evening. I would like to ask you one last quick question. Now, I just reread your book this last week, and I suggest to everyone, if you're like me, and I had to travel a lot pre-COVID, so I used to do a lot of Audible, and because of COVID, I actually found myself not reading books as much as I used to, or listening to books. Please take the time to listen to this book, especially if you want to learn about value-based care. I think that this book will give you an optimistic, and she is an optimist. Anyone who finds solutions with problems the way that she has is an optimist. She's not just a realistic optimist. That's the definition of an optimist. But now, Dr. Lee, my last question for you. Aside from your book, what do you think is the best book to learn about value-based care, or one of your favorite books about value-based care?
All right. Thank you so much. I feel like I need to mail this video over to my mom. I need to send it over. Look what he said. He loved this book. Thank you for saying that. You made my day. So one of my favorite books is actually an older book. And unfortunately, things haven't changed that much in healthcare. So it's still really relevant. It's called The Healing of America. I don't know if you've read this book, Healing of America by T.R. Reid. He's a journalist. And I don't want to give it away, but he has a medical condition, I think it's his shoulder or something. And he goes around from country to country across the world. And he interacts with those people to just see what would they do with a guy like him with a bum shoulder. And he uses the comparisons from across the world it's like a mirror. It's kind of like to really understand our American healthcare system better. And he is a brilliant writer. So it's actually really, really fun to read too. So that's the book I recommend.
Dr. Dan, I think we can start a book club. We can start a book club with the recommendations our authors make and these our healthcare leaders make, and to discuss. I mean, I want to read this book right now.
It's so fun. Yeah, it's a really fun book.
Yeah, I agree. Faisel's Book Club.
There we go. Well, Dr. Lee, thank you so much for joining us tonight. And to our audience as well, thank you all so much for taking time out of your days to come join us. For more information about today's topic and to explore career opportunities with ChenMed, remember, we're on track to open another 500 centers in the next 4 to 5 years across the country. That's at least 2,000 plus doctors, and you can imagine all the support that those doctors, the support teams that those doctors need. So please visit chenmed.com to learn about career opportunities. We believe access to primary care is a right, not a privilege.